intensely. All right, so I just want to welcome everybody to our fourth trauma nights in the series of virtual rounds we've been running at MacOrtho in conjunction with COTS. And this is a special rounds in terms of it being a little bit different in format. So tonight we'll be doing cases and we'll be having some great input from an excellent panel, as well as some excellent co-moderators. So as mentioned, this is a continuation of what we've sort of been going over the last month with various topics in trauma. And we've been lucky to have some excellent speakers talk to us about damage control and polytrauma issues of mobility, hip fracture care, as well as, really interesting talk on patient recovery and priorities and how we should make some of these decisions we make in our trauma patients, and also just help them on the road to recovery. And that's all going to culminate tonight in some cases that we're going to go over and have some great discussion around. And then we're going to repeat the same pattern sort of every month for the next few months. Hopefully we can keep everybody interested and keep some discussions going. And just as a reminder, it's recorded tonight. But we do want to, and so while we're presenting, we want to keep things on mute just so we can hear the presenters. But after the case is presented, feel free to join the discussion by coming off mute. Keep your videos on so we can keep things a little more interactive. And someday the recordings will be available on our website and we can give you guys a link. Now, just to remind everybody, this is CME accredited. Our admin, Paulette's done an excellent job sort of organizing and getting making this a formal educational event. So she'll be sending around an email afterwards with looking for some feedback. And really, we are flexible and hoping to make this program better every week and are going to be responsive to your suggestions. So look out for that in your inboxes. And I just want to, really turn tonight over to one of our fellows, actually. So I'm going to turn it over to Dr. Julien Chapleau, who's one of our orthopedic trauma fellows, comes to us from University of Montreal and arthroplasty fellowship prior to joining us at McMaster. I think he's had an excellent year here, seeing some high energy trauma. He'll be presenting some cases, as well as some other fellows from across Canada. We'll have Dr. Mathu joining us from University of Manitoba, presenting a trauma case from there, and Dr. Katie Valley from Dalhousie, presenting an arthroplasty and trauma case as well. From her experience out there. And so, we welcome the other co-moderators and case presenters here tonight, but they're going to be presenting to an excellent panel from coast to coast as well. We've got Jennifer Leighton providing her insights from Dal as well. Hopefully Amir Khoshbin can join us. I know he might be a little bit behind, but hopefully we can get him in on the panel.
I'm here, man. I'm here.
Perfect. Awesome. Great. We got him in. And then we got Ted Tufescu here from University of Manitoba. And we're really going to be, really thrilled to have their experience and sharing their insights. But what I'm going to do now is actually take a back seat and turn it over to Julien, who's going to start us off with the first case and moderating the session. And he'll be sort of taking us through the rest of the discussion. So turning it over to Julien, I'll stop sharing my screen and hand it over to him.
Great. Thank you. Thanks for the introduction. It's nice to see so many people in there. Hopefully some more are going to join. So what we're going to do, I'm going to start with one case and maybe ask some questions to one of our residents, and then quickly turn out to the other people on the call to see their thoughts and if they have any comments. Also, if you have any questions, feel free to use the chat if you want to, or just interrupt and ask questions. And maybe Dan Axelrod can help me look at the chat if there's anything and let me know. So I'll start by sharing my screen. All right. So I don't know which residents are there, but if there's one that is willing to answer my questions, they're not very difficult, you'll see. Just feel free to let me know. Anybody there? Mary?
Yes, I'm here.
Okay, so here's the first case, and just to say, this will go on for 15 or 20 minutes, and then we'll turn on to maybe Dr. Madhu, who will also present us a case. So here's your Mary. This is a 74-year-old male. He was involved in a car accident, and he was passenger on the right side, and he was T-boned from the right side. So you can expect that most of the injuries are going to be on that side. Apparently, he had a chest needle decompression at the scene, and then you see him in the trauma bay. This is his vitals, which, as you can see, are not that great. So he's not stable yet. So can you, in a few seconds, tell me your management for this patient in the trauma bay?
So along with the trauma team, I'll go through the ABC first of all. And here it seems like the ARB will be a problem because of saturation at 87. And then eventually, once this is arranged, and we'll have to figure out for his BP, and most likely we'll put the pelvic binder just before we do an X-ray to see if it actually helps the elevating the BP if he's not responding to fluids.
All right, so in your ABC, so for breathing, you're going to put a chest tube on the right side because he still has air entry problems, and start large bore IVs. He has some blood products going on, so he's improving. And which X-rays are you going to ask for initially?
Chest and pelvis.
Yeah, so the usual. Here's the chest. And again, this is they're from orthopedics, but this session is supposed to be a bit on damage control and the management of these patients. So quickly, what do you think about this X-ray?
So I see a residual pneumothorax on the right as well as pleural effusion.
Yeah, and there's something going on. You can see how low the diaphragm is on that side. You cannot really see on this side, so there's something going on. Let me show you, I'm going to skip ahead and show you the scan images just to help you see what's going on in the chest before we look at the pelvis. So what do you think?
So there's evidence of flailed chest on the right.
Yeah, I put some arrows to help you. There's multiple rib fractures. So not clear yet if it's a failed chest because it's a question of motion of the chest, if it's paradoxal or not during respiration, but definitely a lot of fractures. You could see some sub-Q emphysema, some pneumo, some hemo, and he also had a rupture of the diaphragm also. So pretty severe thoracic injury. And now you also asked for the pelvis X-ray. So first question, do you think a binder is going to be helpful considering his BP has improved with the blood products and everything?
No, if it has improved, no.
Okay, and can you describe this X-ray for me?
So on the right side, so AP pelvis, on the right side, there's the disruption of the iliopectineal line, ilioischial line, fracture of the iliac wing. There's dislocation of the right hip and right proximal femur fracture, likely like intertroch going into subtroch area.
Yeah. So pretty severe high energy injury, right? So proximal femur fracture, you mentioned here disruption of multiple lines, that's good. So let me show you the scan just to show you the hip joint. And I'm just going to tell you what I'm looking for. Not a ton of comminution around the hip joint per se, but this is the superior rami that goes right to the head. Okay, so keep that in mind. And then I'll show you the 3D so you can further quantify or actually qualify this fracture, see what type it is. So in your opinion, and again, Marie's a junior resident still, so she's doing pretty good so far, but what type of fracture do you think this is?
ABC.
Okay, which means involving
both columns.
both columns. And if I showed you all the cuts of the axial and coronal scan, you'll see that there's no longer any articular cartilage intact with the rest of the pelvis. So this is associated both column fracture. And the proximal femur fracture, oops, you see it again here, nothing new from the X-ray. So next question, Marie, do you remember what's important in associate both column fractures when we decide if we want to fix them or not? Because sometimes we don't always fix them surgically initially.
The patient age and the displacement.
Yeah, and also the articular congruence is something we talk about. So that's
Yes.
why I put this image here. Okay, so let's go back to our patient now. Having all of these, what well, here's a resume of all the injuries. So you're in the trauma bay. What do you think should be the next step? Should you go to the OR for definitive treatment, or is there anything else we should do before?
Well, we needs to be stabilized in airway breathing before we proceed with orthopedic injuries fixation.
Yeah. So in the whole DCO concept, there's also the notion of severity of injuries, and seems like his thoracic injuries are pretty severe. So that's why we talked about a bit of the hemodynamic instability. But now that this is taken care of, we can now prioritize, and this is why you need to talk with the trauma team. So before we go to the to what you think about the options, is there any input from the panel about how would we should we treat this injury? I don't know if Dr. Leighton or Tufescu has any insight, because this is a pretty severe and probably uncommon injury to have both proximal femur and this ABC type fracture. So would you guys go for open reduction, internal fixation of everything, or stage it, or any thoughts on that?
I think we should get Marie to treat it. She's doing so well. Yeah, this is a fairly complex fracture that would mount up to quite a few hours to get it done right. Be nice to see a reduction view or something in traction, just to kind of relax a little, see what's going on. I think all of us would agree, right, that we'd do something with the femur, we'd fix the femur. And I think the question is really the acetabulum. I think with this much displacement and in terms of mobilizing the patient, I would be inclined to intervene operatively, but provided that he's stable enough for that. So it comes down to that stability, that question you raised in discussion with anesthesia and ICU or wherever trauma team to do that and to approach that. Will take quite a while to do that, Marie wants to do, despite the age, I think, which I think is a question.
So this, I agree, this is most likely going to be a 2-3, maybe more hour case. So fortunately, he was stable enough. He was not on the vent. He was stabilized in the ICU for a day, and then we could bring him to the operating room. Dr. Leighton, would you fix this or go for something else for the acetabulum? I know you're an arthroplasty surgeon also. What are your thoughts?
Yeah, I mean, that's always, of course, the direction I lean, but I agree with Ted. You definitely want to stabilize the femur first, and regardless of what you do to the acetabulum, that's going to make your life so much easier to address that. So I'd have them in traction in the ICU to try and keep this out to length and get some better idea, get some traction views to get a better idea of what's going on here. And so I would fix the femur. I would certainly examine some of these x-rays. I think you're going to have, even if you go with, you know, at the age of 74, I'm leaning towards more of an arthroplasty option potentially, but with that femoral side and the iliac wing comminution, I'd probably be leaning more towards fixing actually.
And maybe a delayed total hip or something.
Exactly, just to try and get some stability first, because if we're going with an arthroplasty option early, I think his chance of, you know, post-traumatic arthritis and dysfunction is quite severe. But I think if we could get some stability through at least one column and get some early healing in that femur, then it gives us a lot more options down the road if need be. So I'd be looking at fixing to begin with.
And do you agree that the best construct for the femur would be a nail in this case, or you would use something else?
I would still use a nail, yeah.
So my only concern, and maybe you can tell me what you think, is that if you nail the femur now and decide to do a delayed total hip, you kind of have to buy that and wait for the femur to heal before you remove the nail and proceed with a total hip, right? So you cannot do it
I don't think your construct changes, you know, your time to union in that sense. So, you know, even if you were to do a proximal femoral, any sort of fixation like a plating or something, you're either going to remove that fixation and replace it, or you're looking at replacing it early. I'd be concerned about replacing it early just with the lack of, you know, with both the GT and LT off, and you're looking at poor stability on the acetabular side. I mean, if we go back, can you go back to the last slide? Yeah, just that posterior reconstruction there. I mean, I think you're gonna have a hard time getting stability on the acetabular side. So then your risk of dislocation is gonna be very high if you're trying to go to replacement this early. Your risk of early failure would be quite high. So I think trying to get some sort of preliminary stability, we're not talking about coming back to this next week. We're talking about coming back to this next year if it's an ongoing issue, I think. So that would be my first thought.
And
I make some comments, Julien?
yeah, absolutely.
Yeah, so I think just for this patient, what he or she is getting the night of she comes in, she needs a lot of tune-up from a trauma standpoint. She's probably just going to get like a little pin and traction. You got to get that femoral head off of her bladder. That's the first thing you should probably do, right? Because, you know, she has a diaphragm issue. She has stuff going on with her entire right side, a flail chest component. So she's probably being intubated. So you need some blood parameters to know what you're going to do. And after that, you got to fix that. I don't think this is a delayed hip at all. That you have so much medialization of your femoral head. To regain and catch up with your offset is going to be difficult. So in my hands, that would get a nail. Then I will do only one approach, even though this probably requires two. And I would just plate the posterior column, as Jen said, because you want to reestablish your most important column for your total hip afterwards. And I know that when I come back, I'm using that femoral head as autograft to build off my offset. But I don't think you can leave this, even though she's 74 like this. And you might need to, you have to do some perk screws for your iliac wing as well, because you got to bring it back. But this is not, if this person was 20, 30 years old, you'd be front and back kind of approach. But in this one, it's going to get a nail in my hands, and I would just wait, make sure she's protected from DVT for DVT prophylaxis. Then I would just do a posterior column plate to bring her column as much as I can lateral and away from that medial side, because it's not only medialized, it's internally rotated a bit.
And would you agree, Amir? I know we mentioned sort of timing. To me, this is fix it, stabilize it, gives them some time to recover, and we're coming back not in the near future, but many months down the line for that hip replacement.
Yeah. So the only thing I've tried this and I haven't been successful is if you are going to do acute for these, it's hard to do them because you basically have no calcar support. Certain companies will make certain implants that help you bypass this. So you can have distal interlocking. So where your stem or your conical component of your stem has a screw that locks distally, but they'll also have a bolt-in trope plate that will capture that piece. And it's very difficult. So for me, it's union of femur, and I can do with anything I want with an intact tube. But I would wait 9 months and stuff, and she's going to be in agony. It's going to hurt. But I would wait for a union of her femur and her troch, because her biggest prognostic of how she does in mobility is that troch in her abductors.
I think just a quick comment for one. I think it's great to hear you talk about expectations and all these options, because I think those kind of, you know, although this patient might not be doing well, is going to be important to kind of counsel them on no matter what option you choose. Just sort of getting back to a little bit more of the damage control, and say this patient isn't doing all that well, and to pick up on a question from the chat, you know, if you're doing like say an X-fix and stabilization type of approach, are you guys, is just a skeletal traction pin enough, or are you guys doing like an X-fix?
Tricky question. Putting an X-fix, it's technically putting an X-fix in an open fracture, right? Because you're gonna, so it is tricky and controversial. I've done it before because one of my senior colleagues did it, and I sort of asked them when I was starting off. Personally, I think lag screws work really well. So if you can do little perk screws, like where your Hanover or AIS, if you could put lag screws, that would be good enough with a Steinman pin. And I'll put my Steinman pin in the proximal tibia in this lady, because I'm going to come back for her nail. I'm going to do her nail rather quickly. So either if it comes in the middle of the night, first thing in the morning, I'm gonna pass a cephalomedullary nail in her.
Yeah, and I think my thought would be, I would always start with that distal femoral traction pin, because that's going to relieve a lot off your acetabulum as well as the femoral side. And you're going to get your traction views, and you're going to play with your weight a little bit, and you're going to see what you get. with the amount of traction that you can balance on this patient, depending on their other factors. And if that's not enough, then you're going to reassess them consistently to make sure that you're safe to proceed with something else. But I would always start with that easy femoral traction pin and reassess each x-ray to make sure I'm pleased with where we are, and balance that against their their hemodynamic status as well.
Yeah, I'd agree. I think in terms of external fixation, it's a traction pin somewhere in the leg to stabilize the patient in the emergency department. And then you deal with the femurs, as you guys mentioned. And then for me, not being an arthroplasty surgeon, I need to create some stability in the acetabulum somehow. And it can't be with external with skeletal traction, because it's going to be 3 months, I don't know, 9 months, however long it takes Jen and Amir to come to Winnipeg and do their procedure. So I have to somehow allow this patient to sit up, mobilize, and in the interim without tremendous amount of pain, right? So that I reassess that. For me, that would be fixation. And the goals of fixation are what Jen and Amir mentioned, which is stability of the columns primarily, and however you do that. So they've suggested going from the back and getting that column as an easier means. Sometimes I think, I'm staying out of their way by doing something from the front, but certainly some sort of stability in the columns, not interaction.
I like what you said about mobilizing and possibly optimizing weight bearing as soon as possible, because that's always the goal with these. And patient expectation wise, I think we can tell them this is a bad injury and it's going to take a while before they're back to their normal life for sure. I'll show you what we did, and then I'll let you disagree with what we did. So options, fix it. I think it's a good idea to do the femur first, just to be able to lateralize that femoral head, and then stabilize, fix both columns. I agree with that plan. Or other options we briefly discussed, do an acute total hip or delay total hip after having fixed the femur. So this is what we did once we had the clearance from the trauma team. So it's both fixation of the columns and replacement at the same time. The idea is once you remove the femoral head and neck, you kind of have access to the whole acetabulum from the side, and you can actually stabilize the interior column through there, through a plate. So this is why there are 2 plates on there. I know this is an unpopular opinion from what I heard, but this is what we did to allow him early weight bearing. So a lot of tricky things with these. You mentioned stability, high risk for dislocation for sure. Length also difficult because everything is broken.
Can I just make a couple of comments, Julien?
Absolutely.
Yeah, so one of the things that, if you go back to the other view, I think it's a little tricky here in a sense too, that you still have a little bit, you're able to get yourself back lateral with your offset, because I think you cemented an aligner into an anti-protrusio cage. Yeah. What did you guys do with that ischial flange? Because what ends up happening sometimes is these patients are neurovascularly intact for the first week or 2, and they're happy, and they come back and this has happened to me, they come back 4 or 5 weeks after, and as you saw this, they're sort of progressing their weight bearing, and they're still going to say, I'm having numbness and tingling in their feet. So one thing that Dr. Gross taught me when I was a resident was you either cut it off or you put it into the ischium. Because as your cup starts to go, it starts to retrovert, and that ischial flange is going to come up and it's going to start touching the nerve. And it's just when they start walking. So did you guys cut it, or on one of the views, it looks like it's in. I'm just wondering how you guys dealt with that ischial flange.
We tried to put it in. It's never that easy, as they say, the technique, but we didn't add any fixation on there. I think it's just a plain flange. No, there are screw options, but you never can get those anyway.
I always take that out and try to tuck it in underneath that ischium, because I'm so afraid of it just spitting out.
Yeah. So I'll just finish my case quickly, because we have other cases to do, and we might go over time a little bit. So full weight bearing for this patient. We did tell him to be careful with posterior approach precautions. Antibiotic coverage, high risk, of course, and HO prophylaxis. I don't know if you guys are routinely giving prophylaxis for these, but I'll just show you quickly what happened a few months down the road. So do you guys go for anti-inflammatory or radiotherapy routinely, or not necessarily?
I do aspirin, 325, because 325 more so than 81 gives you HO prophylaxis better, not so much for DVT. I do Celebrex, and I do a thorough glute minimus debridement. That beat up a bruised glute minimus is a HO maker, and I always use the water gun, the pulse lavage, to get any bone debris out.
Yeah, I agree. I do DVT prophylaxis. I mean, this patient wouldn't be on ASA, they'd probably be on Fragment, but I do Celebrex BID for all my patients, primary revision. Unless they're on the verge of dialysis, they all get Celebrex from me, and I just ignore internal medicine's recommendations.
I never went posterior, so I never got HO, remember? So I'm good. I don't routinely prophylax folks. I mean, this is a pretty extensive approach in the end, so perhaps, but I mean, it is what it is. I would use medical management with indomethacin if I could for this. If I were to go and resect the HO, then I would organize for radiation.
Yeah, so we did remove the HO in January, and this is today's X-ray in clinic. He's actually able to flex, to stand up and to walk. So I think overall we're happy with the result with this bad injury. And chest-wise, he didn't need anything to be done on our part for fixation.
I think just to kind of take some take-home points for that, though, we discussed a little bit at the beginning how to stay out of trouble and potentially get things to heal up, and some other tactics in case you don't have, this, level of resource to kind of jump to this option, especially acutely. And now we can also see some of the perils of potentially jumping to this as an option too soon. But some very interesting points coming up, and hopefully we hear some more, I think, polytrauma points in the next case. So I'll turn it back to Julien, and we'll keep moving.
Yeah, maybe maybe one of the other two moderators or fellows have cases to share also?
I think Madhu has a case, so.
Dr. Madhu?
Here, I can share my screen here, Madhu.
And then I think Katie Valley will follow with her. So we're on maybe a little bit over time if everybody's okay with that, but I think we got some good cases to discuss. So hopefully we get to
Can you see that, Julien?
Yep.
Okay, Madhu, I don't know if you want to take us through this or.
Hello.
Yeah, we can hear you.
I think he's having some difficulties. Madhu, jump in whenever you want, but do we have anyone that might take this case from the residents?
Yeah, let's let Julien pick on someone.
Julien, you pick on someone.
Let me see who's there. Ahmed, can you answer some questions?
Okay, Ahmed. So this is a young man who's working in a rail yard and gets hit by a train. So he gets brought in to the hospital by chopper. And he's got... Hello, Madhu. Hello. Yes.
Madhu, I woke up.
Sorry, you woke up? Is that what you said? Carry on. Okay, Ahmed. So he's got a few pertinent findings. He has an open wound to his perineum. He has some open wounds in a gluteal area. He's still tachycardic and hypotensive, and GCS is 14 out of 15. And he's got a binder on. He's has some of those wounds packed. He's got a couple of units in. FAST is negative, and he's a really healthy guy otherwise. Okay. And to move things along, you're given this portable AP from Emerge, and then you kind of have a look for those wounds, and you see one of the 3 wounds down below. So can you comment on the AP? What do you see there, Ahmed?
I think Ahmed's mic isn't working.
Or Dan,
I guess, yeah. He's going to try to reconnect.
Okay.
Yeah. Do you want me to, I can do it, or we can just reassign someone else.
Okay, Dan, you go for it.
Sure. There's open fracture. It looks like to involve the perineum. I was sort of kind of trying to figure out this mic situation, so I missed some of the details of the case.
No worries.
But yeah.
Yeah, he was hit by a train. He's tachy and hypotensive. He's got a few wounds around the back and one in the perineum, and we just wanted you to comment on this AP pelvis.
Right. So it looks like, is that a pelvic binder that's on? I'm just not sure if I can see that there on the near the greater trochanter. But it looks like there's kind of a hemipelvic dissociation of the right hemipelvis with the SI joint, complete SI joint dislocation. There also looks to be a proximal femur fracture, but I'd like to get more dedicated views.
Okay. Sure. Does that help?
Yeah, sure. Yeah. So then on that middle view, it looks like a femoral neck fracture, quite vertical. And the dedicated view and AP view of the femoral shaft, there's no shaft fracture. That's obviously visible. And then I would get a lateral as well.
He's an emerge, so they can't really do a lateral. So got these portables. You're lucky to have them. But luckily, the trauma team just whisks him off across through the door to the CT. So you got some selected cuts of the CT. So you got that around the pelvis. Does that confirm your findings?
I think so. Yeah, it looks like the other SI joint looks to be intact, which would be a concern. But the right SI joint looks to be completely dislocated. I don't see any evidence of sacral fracture either. And then there's the femoral
What else is important on those pictures, Dan?
Presence of the gas and the air tracking.
Where though?
It's going into the abdomen, it looks like.
Yeah, front and back though, right? You see it in the front end, so it's in the inner part and the outer part.
Yeah.
So if you go back, now that we know this, you can sort of look. So you're right, Daniel. Yeah, entirely right. So you can kind of see these shadows around the right SI joint disruption, and you can see the perineal wound, and you can see gas on the opposite side of the pelvis as well. In fact, it's kind of tracking down the leg as well, which is interesting. And kind of in the area of the femoral neck, as well as inside the pelvis, outside the pelvis, all over the place. So, so that's kind of where you're at. You've got these injuries, this open pelvis. It does appear that it's just that SI joint area. So it seems that somehow this train hits him on the back, right side somehow, and this is what he gets. So he's got this large, massive injury to the back of him and kind of the right side. SI joint on the right side is disrupted, the femoral neck, and these wounds in this open situation. So what do you think? Like, can you prioritize some management for him?
So I think, first of all, treat it as a high energy injury, to treat it as if it's a grade 3 open injury. So both cefazolin and gentamicin or tazocin in terms of antibiotic management in the emergency department. Do as much of the gross debridement as possible. I didn't quite hear where the wounds were per se. I know there's a perineal wound, but is there another wound somewhere nearby? I'd also debride that.
Yeah, so there's 3 wounds. There's the one you saw, and then ones you can't see that are around the back, around the gluteal area. There's a couple more near that other wound.
And then, so the priority would be take him to the OR for management of his open wounds, which would be, I think, priority 1A. Priority 1B would be his femoral neck fracture, and then
Daniel,
B would be the sacral fracture.
What do you think about his tachycardia and hypotension? Because we've kind of gone down the open wound, open pelvis path, and we left that behind a little bit.
Right. So it may be due to volume depletion secondary to massive hemorrhage, intrapelvic hemorrhage. I'm not sure. I don't know if there was a binder placed at all intraoperatively in the emerge.
So yeah, so you're right. So it's on there on this portable. You can see it here, and you can see it's actually applied appropriately. It seems on around the greater trochanters more or less. And then when they had a look at the wound, there's the binder there. See it there, unbuckled.
Mm-hmm. So just making sure that the binder is appropriately applied first and they emerge to see if that changes his hemodynamic status.
Okay, so the binder back on, resuscitation, volume, resuscitation, packing the wounds, maybe making sure none of them are bleeding, looking for other sources. The FAST was negative.
Right.
So fair enough. So just to move things along, the binder goes back on, he gets a couple more units, and he actually stabilizes hemodynamically. So you're back to your situation. You've given the antibiotics, the tetanus prophylaxis, broad spectrum.
Mm-hmm.
And so you're still in emerge. So what would you like to do now?
So I think that once the binder comes off, I anticipate he's going to destabilize. So I think I'd have to just make surgical plans for temporary fixation of the pelvic ring, and then management of the femoral neck as well as the open wounds at the same time if possible. So that would be my surgical plan. So first, X-fix of the pelvis if possible, if he tolerates in the OR, and then management of the femoral neck and the open wounds at the same time.
Okay. So do you think there's anything going on at the front in this pelvis, Dan?
No, I think it just needs to be closed from one side.
At the back?
Yeah.
Mm-hmm. So do you think an X-fix would do much for that?
No, it probably wouldn't offer much, but I would be hesitant to put in definitive fixation through the wound site.
Yeah.
Doing PERC or going posterior. So I think if I felt comfortable going PERC with this, transsacral transiliac screws, then I'd do that. That'd be one option here.
Right. So a bit of a conundrum because the X-fix is not going to do much. So a binder, a sheet, or a C-clamp might do something at the back, or a screw or something, right? But he's stable now, luckily. So you want to do everything. You want to do something for the pelvis, wash the wounds, fix the femoral neck. Okay.
I'm sorry, I have a question. Is
Go
there
ahead,
any
Julien.
indications for diverting colostomies in these cases?
Yeah, so that's a great point. We saw that wound. It's right in his perineum, and the other open wounds, which I didn't show you, are in close proximity, and they do communicate. It all communicates with everything: pelvis, femoral neck, potentially. So the general surgeons, and so we're talking to them, and they jump on now, just like you suggested, Julien. So they actually want to look in the belly. There's a few findings there. They don't think there's bleeding, but they want to do that, and they want to look at the bowel and the rectum. They want to do a diverting colostomy, which is great for everyone. So they actually rush him to the OR to do that, and they want to go first, and we let them because he was stable, and honestly, adding an X6 I didn't think would add much to this. So they've done that, Julien. So the idea there being, of course, that now he's got his bag on his abdomen. They've cleaned up the bowel, closed it off, and so we're not going to get fecal contamination around the pelvis. So,
I don't
Julien,
want to rush you, but maybe 5 or 10 more minutes before we go to the next case, just so everybody has a chance to.
For sure, yeah. So I think what we're proposing here is a big operation, right? So just going back to our damage control or whatever, there's a lot to do, and I don't know if I can show you this one. Can't quite skip ahead, but he's actually got a bit of a knee dislocation as well. It's got 3 ligaments out, although the leg is neurovascularly intact and it's stable enough. So there's a lot to do. So is there anything else that we need to consider in terms of how much we do, even though he's no longer hypotensive?
Yeah, I mean, we can consider getting some preliminary blood work, seeing what his base excess is, his lactate, his markers of resuscitation are, and to see how he's doing.
Okay, what do you guys think? And you can ask a friend, Daniel, because I don't mean to.
Sure.
You're doing fantastic though.
In this circumstance, I'd say this patient is not adequately resuscitated. Base excess greater than 2, lactates nearly 6. Now, granted, if we just resuscitate him, it probably will bring the lactate down a bit. Doesn't necessarily mean he won't like kind of shock back when we take him to the OR and he has more blood loss. But I think that he's not optimized just yet.
Yeah, and it's interesting because at this point in time, in conversation with the anesthesiologist, they would have let me do anything I wanted. He looked great. He's just a young guy who, his hemoglobin's through the roof. His vitals are great now. So it's kind of interesting to contrast those two pictures. Luckily for everyone, it was actually pretty late at this point, and I was getting really tired, so I didn't want to do too much. I actually stressed his pelvis a little bit, so there's some images. The image on the right, so they're both under stress, and the front of the pelvis is fine. It's like a reverse APC or something, and the right SI joint opens as much as you see there and no further. And to do my lavage of this, I made an incision as if I was approaching a posterior approach to the pelvis, so just an incision lateral to the PSIS on that side. And everything was completely sheared off, the musculature right throughout, everything communicated with everything. So you could see everything. You could see all his muscles, the fascia, and you could see his posterior SI ligaments that were mostly intact, with the exception of up top. And you can actually move his SI apart, and it would be retained in tension by the remaining ligaments at about that distraction there. So it was very strange, but it was kind of stable in a sense. It wasn't bleeding anymore. So we washed it out thoroughly through all the wounds. And then I started debating what to do with the femoral neck. I'm just kind of moving this along here, Herman, but stop me, or Amir or Jen. But I decided that a bit of gas in the femoral neck, I followed the wound as far as I could. I took out a bunch of gluteal muscle that appeared to be necrotic already. I decided not to do an open washout of the femoral neck and leave it. For now, it actually looked quite clean. It was a giant Morale-Laval lesion. So I left it for there. There's the knee, there's the neck and traction. So at this point, he went off for the night, and then I planned to come back the next day. It's not a lot of time to wait, but we checked on him and he was better resuscitated. We didn't want to wait too long to sort of intervene with respect to the pelvis, the neck, etc. Herman, were you going to say something?
And just a question about, like, did you consider like any temporary pins? Sometimes the concept of like a resuscitation transsacral screw or SI screw comes up, where it's not perfect, but we sort of put it in to hold things, or even with that neck, maybe like a pin or something to hold it while you kind of came back while they're more optimized. Or...
Yeah, that's a great point. And the role of the rescue screw, which I mentioned, is one of the ways to control the back potentially, but he wasn't hemodynamically unstable. He had these intact ligaments that were holding him together. He had a neurovascularly intact leg, and he was in a terrible position to put that screw in without potentially doing some damage. So I decided that it wasn't worth it for him. There was no benefit.
The other sort of question that sometimes comes up with these patients who have bad rotationally unstable pelvis and a perineal type of wound is, when you think what GenSurg sometimes needs to do for their part, they're putting these patients up in like a lithotomy type position, and that's an external rotation force on that pelvis. And it kind of brings at least a discussion at our center of who really goes first. And I advocate, and this one doesn't seem like it's that pattern, but the one that you think is going to open up when they go in lithotomy, maybe putting the X-fix on first.
They might have reduced this one in lithotomy, actually. Yeah. So I guess came back next time, and the next points of debate is we're probably going to leave that knee for a while, right? I think we'll agree on that, is what to do with the pelvis and the femoral neck. Obviously, another washout to the Morale-Laval lesion. I don't know if there's any input from anyone. Amir, I don't know if you have any thoughts. Pelvis. Yeah, I know you do. I know you have lots of thoughts. You're just sitting there going, "Oh."
No. I just wanted for the residents to know, breaking a ring in one part is very rare. this is a very rare injury. Like you don't usually just get an SI. Like there's no rami. I couldn't see any on the CT or even and there's nothing in the front that the pubic symptom. So it's a very rare injury. And just one other thing I was going to say, I've done a resuscitation screw once. Like I just took a 16 jammed it in there. Then when I came back 24 hours or whatever it was later, to get your track for your proper transiliac transsacral screw is so difficult. Because you got to take that screw out, right? You don't put a washer, but then you can't find your new hole and it starts to bounce. And that just becomes so much difficult. So I haven't had success, but if you have access to a C-clamp, it's great.
Mm. Yeah, so to your point, Amir, eventually I did these screws. So I have very low threshold for doing a tension band type plate or some other motor fixation at the back. He actually has some little sacral fractures on the left side that we didn't quite see fully. They're quite stable and minimally displaced, but all the more reason to go across to the other side. But I absolutely didn't want to do a tension band plate because of his moral valve lesion. And once I put that first screw perpendicular to the actual SI screw, I kind of thought, oh, I'm just going to go to S2 and go across. But there was no room in this patient to go transsacral, which is why I jammed another screw in the S1 corridor. So had I prepared a little better, I might have gone transsacral in S1. There was lots of room in S1 actually. But he had tremendous bone and a very weird fracture pattern. It's not what you might expect. So I think that'll be enough for him. And then in terms of the femoral neck, what do you guys think, Julien or Dan? Do you think it might go closed reduction, open reduction? Go ahead, Julien.
You said you washed it initially, so it depends where the incision was, but definitely.
No, I didn't. I didn't actually wash it. I actually positioned him to go and do some sort of approach, like an anterior approach to the femoral neck, and I thought just because there was gas there, but then I really found pretty much zero contamination at the back, and I decided against it.
So if you do those screws supine, I think that's ideal to treat the neck at the same time. And if you have a good reduction like you showed us on the fluoro, I might
consider screws for the neck, or
no? I'm sorry, the posterior ring screws. The S1
okay,
screws.
sorry.
So I would keep the patient supine and maybe use a sliding hip screw device for these higher injury necks. If I feel that my reduction is not perfect, I wouldn't hesitate to, despite the recent literature, to open it in the front and have a better reduction. I think that's the most important part.
Yeah,
I would definitely try to fix it as soon as possible in this young patient.
Yeah. The wounds were difficult to get to pretty much in any position other than prone. So I usually do those screws supine if I can, but I'm okay with doing them prone just fine, just as well. So we went prone and we were able to do another washout the next day at the back, and then the screws went in prone. So then we had to reposition for the neck. That was a different position. So this, let's say this is your closed reduction on the neck on the right. Is that good enough? What do you think?
It doesn't quite look good enough now, but sometimes with the compression you can have, it actually improves. So I would maybe position key wires and start and see if I can get good reduction. I mean, if I can avoid to open it, I think it's better.
Okay. And what do you, is this like on a OSI type table or a fracture table, or?
Probably on the flat top table to do the pelvis at the same time. Maybe have some traction and people helping for manipulation of the leg.
Yeah, I mean, I think one point to be made, and Jen and Amir, and Herman, you can correct me if I'm wrong, but if you start out with this femoral neck and on a fracture table, which I don't use ever, but if you do, which is perfectly fine, and you can't get that closed reduction, then you may want to come off that table and go on a flat top to get the full reduction. So there is that step to consider. There's a study out of Amir's neck of the woods from a while back that looked at antegrade nails on a fracture table and on a flat top. And one of the very few differences, there really weren't a lot of differences, but one of them was setup time of about 20 minutes with a fracture table. So that's the one thing I can control. 20 minutes is a lot of time, so I don't use the fracture table. And I would go to an open reduction in these. This one had that gas, so another reason to go open. But I don't know if Jen, Amir, or Herman, what you guys think.
I would just, there's a picture on the CT, you can see that there's gas in the iliacus. My elective practice, I do a lot of anterior hips. So for this, I would do a lateral window that comes down to a Smith B. So I can get an open reduction on my hip, plate my hip. Well, I would just start with the back. So I would do my lateral window. I can put a clamp, a young Luther's, a clamp the SI, pass my SI screw, wash it out, because there was some fluid on one of the views that you can see. I think it was one of the views in the iliacus, or the inner table. I wash it out past my screw, and I just extend them down distally, and I have access to my femoral neck. I can get a good anatomic reduction. Opening the femoral, like actually doing a formal open reduction, is very controversial. But I would just want to wash it out. So I would just do a iliowinguinal that came down to a Smith P, and I would just do everything supine. But getting your DHS in is difficult. Then you would need a separate approach almost. So it would be a big lateral window, Smith P, and a lateral approach for my DHS.
And then would the rest of you guys do DHS type fixation or screws or?
DHS. DHS with basicervical screw, some kind of derotation screw, I think.
I was gonna say I would do a DHS, but also, or sliding hip screw, but I also add some derotation screws, at least one, particularly with that vertical fracture pattern.
I think I'd be similar, with Gerard sort of mentioned a few weeks ago that potentially cannulated screws might be a better option, and sort of pick your complication and what you want to tolerate. But, for me, I still lean towards a sliding hip screw and anti-rotation. Open reduction, I think, is also an important point. But the key is trying to get the reduction perfect. You can get that closed potentially, but if you need to go open, I think you got to do it.
Yeah, I think you can do a lot too through that. Depending on, I agree with Amir, like I'm worried about that iliacus gas and debris up there. So I would be pretty aggressive with that. But I think you can get a lot through that lateral window that you're using your DHS through to really help with your reduction along that anterior neck as well. So I wouldn't hesitate to be aggressive on that front as well.
Yeah, so those are all good points. And I agree with all of them. Yeah, so I think I'm okay with a closed reduction. I just tend to do an open reduction, but it's controversial, as Amir said. I just find it difficult to convince myself that I have the reduction. There's a fair bit of comminution on that CT. If you go back and if you convince yourself that this is an open femoral neck fracture, well, I'll tell you some of those bits and pieces were completely free of soft tissue. So maybe another reason, again, very strange case, but another reason to do an open reduction and then do that open reduction, well, to irrigate and then do the open reduction. So, and in terms of the DHS, I have nothing against the DHS, and it's a very unstable fracture. This is just my preference, so this is what I did. His bone is excellent, so his fixation was anatomic and compression throughout, and so I was happy with that. And
I think that looks great.
Looks great.
There's his reduction there, and there's those screws there. And general surgeons did a post-op CT for other reasons, and I looked for that S2 corridor. In retrospect, couldn't really find a very good one. So
I was going to say sometimes those surprise post-ops are humbling, but it looks like this was an awesome one to see. So
Yeah.
Ted, what is your post-op weight bearing status for this gentleman?
I would keep him off the limb. So I think that it's important to remember all his injuries. Everything's essentially loaded. The bone's loaded at the side joint at the femoral neck. He also has that reconstruction. One of my partners did something with his knee. I don't fully understand, but he had that done much later. So he's got all this on the right side. I'm okay with him walking on that pelvis. Likely, I'm probably not so much okay with him walking on the hip, and I don't know about the knee and his soft tissue injuries. I think he's got a debridement and some stuff going on for his soft tissues at the back from plastics now. For my young femoral neck patients, I tend to keep him off for a bit, which is completely different than my elderly patients. I think they're different groups of patients. So They can do different things. They can partially weight bear. They probably won't anyways, because he's a young male, so he won't listen to me anyways. He'll do as much as he can. But in terms of mobility, once you have an osteopenic fracture and you're in that other category, then you're going to walk on whatever I fix. So kudos to you guys for doing that total hip in that previous patient, because I wouldn't have been able to get him walking, right? For him, it's a little different.
This is a great case. I think we're close to the end here, but if you guys are okay, we can continue for 10 or 15 minutes. I definitely understand if people need to log off at some point, but if you guys are okay, we could go ahead with Kate's case and just have a look in 10 minutes or so. Sorry about our...
Yeah, no, I'm sorry. Sorry about that, Kate. I thought I went as fast as I could. Yeah.
Great case, Ted. And this one will be a little bit faster. This one's designed more as a short snapper. And I knew you guys were going to cover some of the polytrauma damage control issues. So I thought just to bring us around to, it's not a hip fracture, but to some early mobilization and patient expectations type themes that we've covered in some previous weeks. So Kate is one of our trauma arthroplasty fellows in Halifax. And she's currently on the job hunt, so tell your friends. And she has done a great job putting this case together for us today.
Okay. This case is a 79-year-old female who had a fall from standing at home when she was getting out of bed to turn off the light. And she described it as feeling that the knee gave out on her, which was what caused the fall, not necessarily tripping on something. At baseline, she uses a cane or a walker to ambulate, but she tends to be reluctant to use ambulatory aids and generally not terribly active, and lives with her daughter and son-in-law. So in terms of her past medical history, she's got a diagnosis of multiple myeloma, and she's currently in a trial on some medications there, including dexamethasone. She's got a history of type 2 diabetes, CHF, hypertension, dyslipidemia, urinary incontinence, and a prior history of arthritis and CPPD arthropathy, primarily affecting the knees. And she's quite symptomatic. Actually, her rheumatologist described her knee pain as her most concerning symptom and her most limiting factor in terms of mobility and quality of life prior to this injury. So on her preoperative evaluation, she had a hemoglobin of 77, platelets of 60, glucose of 12, and an albumin of 25, notably. So if we look at the CT scan here, hopefully these play smoothly, but you can see that she's got quite a short distal end segment. There you can appreciate the significant patellofemoral joint arthritis, as well as the subchondral cysts throughout the bone. They're fairly poor bone quality. And as well, a significant amount of medial comminution. So if there are any residents or who want to sort of talk about what the major considerations would be for this patient and determining what the best treatment option would be at this point.
Since I know everyone on the chat, I'm going to volunteer someone. Let's do Mo Siraj is there. Mo, do you want to answer?
After the x-rays, Kate, just so he has something to look at while he talks. It's always easier.
For sure.
Sure. Yeah, I'm just in ICU, so I might
Not that helpful, but
so sorry, remind me of the question, just what to do.
Yeah, essentially, and what are the sort of major considerations for this patient when you're trying to determine what the best treatment choice is at this point? And I'll go back to her past medical history as well.
So it's comminuted distal femur fracture. I want to know if there's any articular involvement to decide on a construct. The other thing is she's pretty sick, a lot of medical comorbidities. So you're worried about perioperative morbidity and mortality. Getting her ambulating is going to be a big priority. So a construct that she can weight bear on would be preferred. So I can't remember if the CT scan showed anything going into the joint or not.
We'll go back to that.
With her cardiac comorbidities, I'd give her a unit of packed red blood cells pre-op as well and get a medicine and anesthesia consult. So it doesn't look like it goes into the joint.
Mo, she also said that the patient had previous arthritis, which you can see actually there.
Yeah.
That she was already symptomatic. So that's another factor that you can use is the pre-morbid condition. And as you said, I agree, you want to get this patient weight bearing as soon as possible, or at least moving as soon as possible.
Yeah. So I'd lean to a distal femoral replacement for her, especially with the severe arthritis. I think it's a little too distal for a retrograde nail on top of that.
All right, so advance to the next slide there. So these x-rays are actually from a 1.5 years prior to her injury, just again demonstrating the degenerative changes there, primarily in the patellofemoral joint as well, which again was quite symptomatic and limiting for her. So when we were considering treatment options for this patient, essentially looking at fixation versus arthroplasty. So the things pushing us towards arthroplasty in terms of injury factors were the degree of medial comminution, the very short end segment, and the existing symptomatic OA, as well as the overall sort of poor bone quality. In terms of patient factors, her age at 79 makes her much more amenable to an arthroplasty. Her poor pre-injury mobility, so like you highlighted, very important to get this patient mobile post-operatively. And then her history of multiple myeloma on dexamethasone, diabetes, and low albumin. So she's a poor candidate for good bone healing as well. So probably less likely to be a successful.
Hey, can I be controversial?
Yeah,
Please do.
Yeah, so patient factors, so those diabetes, low albumin. So I guess from the K-Ford study and other retrospective case series, the ones that had the most amount of difficulties with the wounds were the DFRs. Right?
Yeah, that is sort of the trade-off, is bone healing versus wound
Correct.
healing issues. Obviously, when you're putting a large arthroplasty component in there, you're concerned about wound healing and infection potential. So for sure, that may not alone push you away from fixation to arthroplasty. But I think in the context of all of the other factors, it's just something to consider.
One other thing I would also want to mention, you said multiple myeloma. You would need to scan her entire femur, right? Because if you're going to do cemented DFR, you're going to go up to some kind of isthmus fit up further proximal, right? You got to make sure there's nothing else happening, because with a nail, you've at least protected everything, right? You protected her entire femur.
Yeah,
right?
she has
Some of these factors.
tibial lesions as well, Amir, too, which is definitely a consideration.
Absolutely. Like I love arthroplasty, like, I love doing the arthroplasty, but some of these factors can play for both, doing the replacement versus doing the fixation. So it's a very difficult decision that needs to be catered for every patient, because we don't know the right answer at present.
Exactly. That's why I thought it was a good one for discussion here, especially in front of a trauma panel. So I'm glad, as a fellow arthroplasty surgeon, you brought up those controversies, because I was trying to stir up the pure trauma surgeons to get in my face a little bit,
Yeah. There's a COTS RCT coming out, so across Canada, and there's some spots in the US. So to build off what the K-Ford study did out of the UK. So we don't know the right answer. I know Herman's done a systematic review that's going to come out soon as well. So
and it's clearly a topic that's near and dear to our hearts, but I think it gets into what we sort of alluded to at the beginning, and great case, Jen and Katie, but sort of just to bring out like expectations, right? Like you bring out these patients were lots of things maybe pushing us to get them mobilizing early, and that's good for a lot of reasons, but the expectation of risks of infection, these guys are frail, even in a patient who doesn't have issues with the myeloma and a canal, there's still potentially risk for periprosthetic fracture with these really stiff, rigid implants, right? So, I mean, we kind of decide surgically relatively quickly, but the expectations are something that need to be taken into consideration for years, months and years, right?
Yeah, exactly. And I think the big thing, we had a really great session. Was it last week? We went through the expectation stuff. And, with these patients, I think we touched on it a little bit, but you're not necessarily convincing the patient, you're convincing their family. They're often the classic Nova Scotian case is the daughter that lives in Toronto that has deep feelings about what should happen, but can't be here to help out.
That must be one of Amir's patients.
Yeah,
exactly. She's been drinking the Kool-Aid in Toronto. Exactly. God knows what her expectations are. How could I ever meet them if she's already met Dr. Khoshbin? So, I mean, it's a tricky path to walk, but it's a long conversation. For, like you mentioned, Herman, we kind of go through the imaging, you look at the pros and cons, and you go with what you think is best, but then that decision happens fairly quickly, and the conversation's pretty long to walk the family through it, because you have a lot of considerations. And for her, the other one that we talked about is she's undergoing this chemotherapy trial for myeloma. So the disruption in the trial and her long-term health. And if she does develop a periprosthetic infection from either surgery that I do, then that's going to limit her ability to receive chemotherapy and may limit her longevity. So it's a challenging conversation either way. I mean, Kate, why don't you go through what we did and some of the discussion around that, and then you guys can yell at me if you want.
I would never do that.
Yeah. You knew what I was gonna do.
Perfect. Yeah, Jen, why don't you comment? Like, one of the hardest things having done these is how do you get your maybe comment on your rotation of your femur? It's always more ER, and the length of what you're going to resect, because that's always the tricky part on these.
Absolutely. So I always I use a standard medial parapatellar approach for these, open it up proximally and start by carefully resecting the fracture fragments. That's probably the most satisfying part of the case, because especially in a patient like this with multiple myelomatous bone, it's just crumbling in your hands and you're just thinking, thank goodness I'm not trying to put screws in this right now as you're taking it out. For the hardest part for this is kind of, like you said, determining that level of resection. So I always start with my lowest possible level of resection, just proximal to the fracture. I go down and take my standard tibial cut and build off the tibia. And then it's about trialing my resection length, because you really can't measure these off of the preoperative x-rays like you normally would. And then for determining my rotation, I'm really relying on your patellar tracking and your trials to set that. And the key is to really mark it. I make a notch in the femur once I've set that rotation before you take everything out, because you completely lose all your landmarks, as you know, once you take out your trial. So it's a lot of trial-based resection. And if I could critique myself, I've probably raised her joint line a smidge here. I think, these implants, actually, this is my first time using the system, and it takes a whacking cut off the tibia. That's a little bit aggressive, but anyways,
that's great.
It's a nice system. And I think one of the points too is that even not using this particular system before, it was still, like a 70-minute procedure. So when you talk about trying to cobble some of those fragments together and the infection risk versus, surgical duration, I think in my hands anyways, this was a faster procedure to replace personally.
Wow, looks great. I was going to answer Daniel's question about the role for hybrid nail and plates. This was actually one of the COA things that Dr. Leighton Sr. did last summer. We're going to see a lot in the next decade of intraprosthetic fractures, people that have hips and that have total knees. And I think the best thing for those is a hybrid nail plate fixation. So you pass a very small nail, you get it as close to your distal end of your stem, then you protect the entire femur. No matter what you do between these two intraprosthetic fractures, you have to protect the whole femur. So I think the best combo for nail plates is those interprosthetic fractures.
I think this one might be a little low for it. Sorry, Herman. Yeah, but you know, not having this option, which looks fantastic. Once again, you guys are putting me out of business. But you know, I look for these folks. They don't. If you fix them, octogenarians, they don't live and fail. You know, have their fixation fail. They either live or die. Very few of them actually in that age group live with a non-union or some sort of failure. So I just throw everything at them, and for the most part, they live or die sort of thing. So you let them weight bear. And if you were to do just a standard construct with a long plate, et cetera, that's probably enough. But I look for other opportunities, and the nail plate concept, I really like that. And just a little reduction plate is one of the things I like to do. And again, this is probably a little too low for that. Just on a lateral column, just to kind of get things lined up for yourself. And then a retrograde nail with some kind of fixed angle sort of blocking device distally. And you can just swing the arm to the medial side because the plate's on your way on the lateral side, and just lock from the medial side. And you've spanned the whole thing, you've reduced it. It's not terribly difficult, but you got to make sure that whatever that implant is that's locked in, the spiral blade or whatever, actually is in bone as opposed to in the fracture, which may be the case here. So that looks really great, John.
I tell all these patients that you're going to be short. If I'm going the fixation route, I always tell them you're going to be short. The shortening is my advantage. It's going to give me union, a chance at union at least.
Yeah, that's a great point. Yeah, living
Aside
with a
from
shoe
the-
lift. Yeah.
Sorry. Aside from the nail plate construct, for when we talk about sort of early weight bearing in this patient, this fracture, you know, to me led me down this path, but you know, maybe with a slightly higher fracture pattern, are you guys using medial plating or intramedullary plates or struts? Like, are there other adjuncts in this population that you would throw at it for to allow your early weight bearing?
An open medial plate would be something I would use more in a non-union setting, where I'm actually pushing on a intact bone, but with so much comminution, I would think about some sort of internal strut, or so that could be a nail, it could be a fibula, it could be a plate from the medial condyle up.
Yeah.
That you then capture with probably the easiest thing. So you could do any of those things. Probably the easiest thing to do is what I described previously. Sorry, Herman, you're gonna.
I was just going to say, it kind of, you know, depends on your resource availability, and we all kind of have different things at our disposal. Some places have a good bone bank where they can get a fibular strut. You know, if you're not, I've definitely been places where I don't have that as an option. So I've pulled the medial plate out a little bit more frequently. But you know, the concept is just giving it the rigidity and the support you need to get that patient up and moving, and trying to add an adjunct and not just falling down and going down a tunnel, just, you know, one implant, one fracture. We have options at our disposal.
Absolutely. And Kate, I think you had a little bit just around the weight bearing stuff, just to maybe roll it out with some evidence for some of our residents here.
Yeah, for sure. So just spinal x-rays there and doing quite well at our 2-month post-op. And then, yeah, if we look at some of the data around weight bearing, I mean, it's fairly intuitive that early weight bearing and range of motion would benefit patients. But if we look at the data, in general, after the age of 30, is about 3 to 8% loss of muscle mass per decade. And in the older population, there was a study that showed almost a kilogram of lean muscle mass loss after only 10 days of bed rest. So it's not insignificant. And of course, this leads to more difficulty with balance, higher risks of falls, and overall mortality. And then the main thing is as well prolonged hospitalization, and then increased risk of institutionalization as well. And then if we look at the American population, which, you know, is fairly similar to ours, that a decent proportion of people are already sarcopenic, and as that increases, so does the likelihood of disability, and again, needing higher levels of care and prolonged admission. And so when patients come in with these types of injuries, if we put them on bed rest, even sort of as short as 10 days sort of time span, it might just be the tipping point that pushes them over the edge and really impacts their mobility and their ability to live independently as well. So for these distal femur fractures that are low energy in elderly patients, we should really be thinking about them more like hip fractures, as we already know that non-weight bearing status in hip fracture patients significantly compromises their functional level. And so if we think of these fractures more like a hip fracture, we might be able to improve the outcome for these patients. And we talked a little bit about when sort of you would allow patients to weight bear after fixation and some adjuncts that you could use to improve that. And then when we're debating whether to fix or replace in these patients, obviously taking into account the average time to healing. So if you're not able to weight bear them or you're partially weight bearing, considering that they might have to have these weight bearing restrictions for at least 12 weeks, which is largely not feasible in a lot of this population. And then just looking at some general outcome studies, but we covered a fair amount of this. In this one particular study, directly comparing fixation versus distal femoral replacement, they did find better ambulatory status in the arthroplasty patients, which again is sort of intuitive. And they found that the revision surgery rates were similar. So it definitely is a feasible option in these patients. And I think as long as we focus on that early weight bearing and early rehab, I think the patients would benefit significantly from that strategy.
Great, thanks, Kate. Any other comments from the panel? It's a controversial area, so I think it's important to highlight, and hopefully with the more data coming out and some of the trials coming, we'll have a little bit more information, because as you can see, some of the best evidence out there is a 30 to 40 case series. So I think more numbers will certainly give us better information around this so we can counsel our patients.
I think one thing that's important, and that came out of that same K4 study from MacOrtho, was you got to make sure out of the 70 patients they had, they didn't have surgeon availability for 30 or 40 of them. So you got to make sure that the surgeon that knows how to do a DFR is doing a DFR, and the surgeon that knows how to fix these is fixing these. It's a tricky thing, because you need to have the availability of both of the subspecialties available. So that was one of the things they sort of picked up, like, oh, we need to make sure that, you want to treat these like a femur fracture, like, you want to treat them as Bs or whatever they are at your institution. And whoever's doing the DFR really knows what he or she is doing.
Yeah, I think that's an important point. Like either way, other studies have identified that if they're waiting more than 4 days, their mortality rate increases quite a bit. So it's not quite the same tight time window as a hip fracture, but the overall mortality rate for these distal femur fractures is pretty much equivalent. It's within 1 or 2 percentage points of a hip fracture. So even though the hip fractures kind of get that morbidity press, because we see so many more of them, these are a smaller percentage, but they're equally significant to the patient and do have that mortality rate with them. So I totally agree.
I mean, it's interesting to kind of bring this up with the discussion we just had with expectations and outcomes. We prioritize things based on different values, but you got to be alive to have the outcomes. So mortality trumps everything. So, whether it's polytrauma or this, we're talking about the importance of mobilization, that mortality benefit is what we kind of probably look at first and foremost. And then we can start the discussion on some of those other outcomes, I think. So I think that, we've kept everybody for a while. I'm going to turn it over to Julien if there's no other comments to kind of close us out for the evening. Unless there's any lasting burning comments from the audience or the panel.
Thank you for organizing this, Herman, and Daniel, and everyone. It's great.
Yeah, thanks, Herman. Great to see some friendly faces.
Yeah, and then thanks to Madhu who got disconnected, but he put the case together, and I got all that glory, so it's too bad. Yeah. Thanks, guys.
I think we had some really interesting discussion about these cases. Some of them are not that straightforward, and we don't all agree. I think that's why it's interesting to discuss those. Thanks for staying a bit late. I definitely want to invite you all to next session, which is going to be May 4th, so next week. We're going to talk about proximal humerus fractures, and Dr. Shimich and Garner are going to be there to give us some talks, and I think it'll be interesting for everyone. So thanks again for everyone for being here and sharing your cases. I think that was great.
Thank you.
Thank you guys. Thanks for having us. Bye now.
Thanks, guys. Have a good night.
Thank you. Have a good night.
Bye, everybody.